Good.
All right. Good evening and welcome to Physician Research Center's Cerium Journal Club. I am Jahan Marcu, a cannabinoid researcher with many years of experience, and Cerium is one of the pillars of PRC Plus. It's the educational program. It's designed for the busy healthcare provider who wants to understand cannabis and its derivatives through the lens of science. We'd also like to thank you for taking the time to participate in this journal club, but it'd be great if you could scan this QR code and participate in our quest to continually understand the healthcare provider that we're trying to provide service and improve our programs for. Additionally, we have our third pillar, Buds Info Analytics. This is an adverse events data collection, something you can share with your patients and anyone who has tried or uses CBD, hemp, cannabis, and all those types of things. You can check out our website if you want to learn more at prc-trials-plus.com. Just a shameless plug. My colleague Andrew Peterson and I just published a book entitled Regulated Cannabis and Hemp Market Navigation, Business, Public Health, and Research Challenges. It is available at Barnes & Noble and Amazon and where books are sold online. I'll also be presenting at the Society of Cannabis Clinicians event in October 12th. So if you're in Maryland and want to stop by and get a copy, please do.
An
Also,
autographed copy?
yes. And if you want to leave a review, please contact us. We can send a book if you do book reviews or would like to look at an excerpt or a section of it. I'd also like to thank Mother to Baby for helping promote this webinar. We are doing a webinar with them on October 23rd at 2:30 p.m. So keep an eye out for more announcements regarding that. Today, as you can see, I'm joined with Dr. Phil Molloy, who's a rheumatologist who's recently retired from clinical practice in the Massachusetts area, however, remains very active in caring for patients and in research. The Cerium Journal Club that we're going to bring to you today will present a little bit of the paper, and then we'll open it up for discussion about any and all things related to the paper. So the mission of the Cerium Journal Club is to support the education of healthcare professionals with discussions of published research. And we approach each paper with consistency, fairness, and transparency. So before we begin, we'd like to do just a little poll since the topic is on neonatal outcomes and cannabis. So a little participant interaction. Let me just get the old poll launcher up. There we go. And we will launch this poll. And if you could just take a moment to fill out some of the questions, that would be great. So it's just a poll on sort of, do you see patients of childbearing age and who may consider using cannabis? How confident do you feel regarding those risks or choices? How comfortable do you feel having those discussions? All right, well, we'll leave the poll open for 10 more seconds so you can answer these questions. Don't be shy, or be shy. Be yourself, it's fine. All right, closing the poll. All right, I'll just share the results just for a second. Well, 100% of you see patients of childbearing age, and no one says they will not discuss cannabinoids with their patients, so I think is great. And there seems to be a need for thinking about or developing a formal plan or procedure for identifying patients or persons for whom discussions about cannabis or pregnancy may be appropriate. So I think that's perfect for our discussion this evening. So thank you again for joining today's Journal Club session. We will be discussing a very pertinent topic. Given the increasing change in regulations, the rise of cannabis access along with it, and this question about the impact on prenatal cannabis use on neonatal outcomes, our discussion will be based on a systematic review and an analysis conducted by Lowe and colleagues, published in the Journal of Cannabis and Cannabinoid Research, entitled Cannabis Use in Pregnancy and Neonatal Outcomes, a Systematic Review and Meta-Analysis. And before I hand it off to Dr. Molloy, just to give you an overview, I'm sure that many people watching this are aware that the access to cannabis and hemp products containing cannabinoids like THC and CBD is on the rise. In particular, with this growing regulatory changes across various states and countries, we're seeing more access to these products. There are concerns that use may be increasing among pregnant individuals. And despite authoritative agencies advising against the use of cannabis during pregnancy, many continue to use it, partially due to limited safety data. So there's this significant public health challenge. And again, the main concerns are understanding the potential adverse effects on fetal and neonatal health, such as preterm birth, small for gestational age infants, and perinatal mortality. So, Dr. Molloy, let's dig in a little bit more with some specifics. I
Yes,
prepared a couple slides.
yes. Okay, but before you advance to the next slide, I think the last bullet um, speaks to patients being suspicious of drugs in general, and pregnant women have been sort of coached and raised on no drug is good and safe in pregnancy, if at all possible. Well, for some reason, cannabis is slipping through that opinion. The other thing I wanted to mention is that um, the use of cannabis. We're not sure of these numbers because we're not sure how accurate patients are in reporting it. Patients do underestimate the amount and even whether they're not. So self-reported is subject to being questioned, let's say. Um, and in the literature, if you look at the past decade or two, um, how do you know how many pregnant women are doing it? Is it through urine drug testing or some objective measure, or do you just rely on the patient's self-reported, do you take this? So those are all things just to sleep on. Let's go to the next slide here. So I think Jahan mentioned this already. There is a perception that as cannabis becomes more widely available, that it must be safe. Also, THC, everyone knows it's not a secret that the concentration and potency of products has increased a lot over the past 10 or 20 years. THC and other exogenous phytocannabinoids and endocannabinoids do cross the placenta. The ECS is present in all reproductive tissues, quite critical in almost all steps of fertility, pregnancy, and coming to successful term of pregnancy. Not just the cannabinoid receptors, but endocannabinoids and exogenous phytocannabinoids are easy to find in reproductive tissues. There's been a long history leading up to this paper. This paper didn't just descend out of the blue. Researchers have been looking at this question of cannabis use and pregnancy outcomes for a couple of decades. Methodologies are challenging, obviously, and small for gestational age, preterm delivery. I'm showing you some of these abbreviations here. They're widely used in the literature and in this paper. Need for neonatal ICU admissions, APGAR scores, which is not on this slide, and mortality. So there are many other potential outcomes. One of the challenges of doing a meta-analysis is that every article that you are studying and including in your analysis doesn't necessarily have all the definitions and all the outcomes in it. And I would like to pause for 1 second and mention what we are not looking at in this and related papers that I've just alluded to, that we will be looking at in the September Journal Club. What about long-term effects on the offspring? Okay, so after the vulnerable period of immediate neonatal life, when we're looking at small for gestational age, preterm, neonatal ICU, APGAR scores, what about 5 years, 8 years, 10 years down the road? Do these kids born exposed to in utero cannabis have any long-term sequelae, either medical, cognitive, behavioral, or other? I'm just throwing that out there. It's not in this paper. It's not what this meta-analysis is addressing, but it's going to be on the next journal clubs. So let's giving us a plug for next month. So go ahead, next slide, Jahan. Yeah, we don't know how liberalization of cannabis laws state by state right now impacts a pregnant woman's decision whether or not to continue to use or to start using for any of um, distressing symptoms that may occur during pregnancy. We also don't know, by the way, I think everyone here is familiar with the fact that there is a push to reschedule cannabis. Let's suppose it's rescheduled and it's no longer cannabis. Products are on Schedule 1 and they're on Schedule 3. Let's just suppose that actually may happen. What will be the impact on pregnant women's perception of safety if that happens? So there are methodologic issues in all previous epidemiologic studies, like controlling for other things that are known to impact neonatal health, viability, and all the other endpoints we're talking about, like controlling for other substances, tobacco, alcohol, other legal and illegal drugs, controlling for medical problems, diabetes, poorly controlled hypertension, poorly controlled diabetes, all these other potentially confounding variables that influence the outcome of pregnancies are not always formally addressed. Every time, every couple of years, it seems a new meta-analysis comes out, and every time one comes out, it's done a little bit more carefully and thoroughly than the previous versions. The last bullet, I'm not sure most doctors and even most OBs, I would presume most OB doctors know that the ACOG has issued a statement strongly urging pregnant and breastfeeding women to avoid cannabis. I'm not sure the public knows that the Surgeon General also issued such a report. It was not well advertised at the time. I didn't know that until I think it was published in 2018. That's 6 years ago. I wasn't aware of that until 2 or 3 years ago. Okay, next slide. So how was this study done? I will show you a flow chart on a subsequent slide of all the publications reviewed and how it was narrowed down, narrowed down, narrowed down in 53 studies. So think about doing a meta-analysis like this. By the way, many databases, the usual databases, and many others were searched for relevant articles. You know, Medline, Ovid, CINAHL, PsycInfo, Global Health, EBM reviews, Cochrane databases, PubMed, clinical trials, and all these and many others were used. By the way, this study was only searched for publications done in the English language, which includes European, Canadian, some Israel, some Australian sources. So the main outcomes, you'll see some of this spelled out in a minute, and I want to make sure you're familiar and comfortable with the abbreviations. A preterm birth, small for gestational age, birth weight, which is related to the first two, obviously, it's not independent of the first two, and perinatal mortality. You would think that would be rather straightforward. It's not defined uniformly in all the studies that are put into this 30 days, 60 days, 90 days. What does mortality mean? There are many secondary outcomes. You'll see that in a second. And in this study, you were an exposed woman, an exposed pregnant woman, if you either self-reported, not in this study, in this meta-analysis, studies were included that cast a net for users identified by self-reporting or by urine tox screen. A lot of OB clinics do routine urine tox screens, and you can capture cannabis exposure without patient self-report in that situation. So I'll go to the next study. The bottom of that slide, and this slide, by the way, is a reference to the article we're talking about tonight. These are important things to consider. Some of the studies ended up in this meta-analysis because of self-reported cannabis use. And it's been shown in many other studies that pregnant individuals don't admit or underreport the magnitude of their cannabis use. That's been well established prior to this meta-analysis. What about the product diversity? And there's a huge variability. And you are an expert on this, Jahan, but when we talk about in previous journal clubs, when we talked about driving under the influence, anxiety, cardiovascular, this was a big thing. We don't really know the exact details of what the patients are consuming. We know what they're reporting, but that's not always the same as what they're taking from walking out of a dispensary door or buying it on the street. Do you have a comment on that, Jahan?
I think that's a major limitation that's being corrected now in a lot of studies was just check a box. Have you ever used cannabis or marijuana? Not really defining what they mean. And now assessing cannabis exposure is a much more serious business, as a lot of studies didn't account for the timing. When did people use it? How much did they use? As that can influence outcomes, right? If you think about before driving a car, did you use it before or after you drove the car? Could have a big influence on the outcome. And I think that a lot of studies fail to capture that. So one of the things that we'll show in one of the figures is they had this sort of this COE, or I think it's called the certainty of evidence rating. And I think that that low COE rating reflects this limitation. They didn't know, are they, inhaling it, eating it? Are they eating an even mixture of THC, CBD? Are they just having a product that's very low THC? Are they consuming only extracts? Like we really don't know much in that way. And I think most people realize that there is a huge difference in the variety of cannabis products. There's probably 1 million different types of cannabis products on the market in different states in different dispensaries with different ratios of compounds and delivery forms. It's a really astounding issue. So I think that affects the confidence of some of the outcomes.
So Jahan's highlighting three important potential weaknesses in all epidemiologic studies on pregnancy. Number one is we don't know enough, as much as we would like to know about the nature of the product. We don't know enough about the patient's comorbidities and confounding medical issues, socioeconomic and otherwise. And we don't know a very important thing. It's been shown in previous studies that a lot of pregnant women, when they find out they're pregnant, stop using alcohol and cannabis products, and others continue to use. Most of these studies that enter into this meta-analysis just check, have you used during your pregnancy? But you will see if you read the literature, there's a big difference between women who stop when they find out they're pregnant and women who continue throughout pregnancy. If you learn you're pregnant at 6 weeks, um, embryologically, you don't even have the cannabinoid receptors by 6 weeks, but you do later in pregnancy. You could postulate that exposure later in pregnancy counts a lot more than at the beginning. Okay, next one. And we do have some emerging data on that. Go ahead, next one, Jahan. So this is for people who like to analyze meta-analyses. Um, this is how many studies, starts with how many studies that they put in a bunch of search words and searched all these databases, English only. That's how many at the top of this page, how many studies they started with, removed duplicates, removed things that didn't have appropriate endpoints, or they didn't report enough, um,
I would say
or couldn't valid.
this is a
Yeah,
huge strength for me of any study. If there's a review or meta-analysis that doesn't have this, and if it's a narrative review, that's one thing, but any meta-analysis or systematic review that doesn't have this type of figure, um, it's it's hard to take it. My level of confidence in it goes down. So I love seeing this in any paper, like kind of a flow chart for how they determined
yeah,
what to include, what to
yeah,
exclude.
yeah. Okay, we can go over the next one. Anybody can, hopefully you all have this article too. Go ahead, next one. So here's the primary outcomes. Preterm birth, PTB, SGA, small for gestational age, and perinatal mortality. However, it was reported in the 53 papers that made the cut. Now, the next slide shows some secondary outcomes. Oh, I would like to pause here because Jay and I were talking about this earlier this evening. Not every study reported on mortality. Not every study you read on outcomes on cannabis and pregnancy will specifically talk about mortality. However, it's been previously shown over and over again that preterm birth and small for gestational age are strongly correlated with mortality. So if a study reports PTB and SGA but not mortality, in a way, you can extrapolate that PTB and SGA are surrogates for possible increased mortality. And the authors wanted to point this out. And I think it's worth pointing out.
We might have a question, I think. Dr. Molloy, could you take a question right now?
Sure, go
Uh,
ahead.
Dr. Liu, is that right? I see you have your hand up.
Oh yeah. Sorry.
Did you have a
Uh,
question?
yeah, I just wonder the both outcome establish more Jackson A and then put term label, and do you have the other type of outcome? For example, malformation. Yeah, I will evaluate that.
You know, those are all,
Like,
that's a great question and great points. And no, they were not analyzed in these
yeah.
studies, and it was not a focus of this meta-analysis, but that's a great question
Okay, thank
because
you.
there's some information out there about malformations,
Uh-huh.
not a lot.
Okay, thank you.
Thank you. Great question.
Okay, go ahead. Next slide. Okay, so these are endpoint details. This is the first slide that actually has results on it. Um, and as you can see in the left column, not every study covered all the bases. This is a meta-analysis of multiple other studies. For example, look at preterm birth. Only 41 studies reported on it. On mortality, only 17 studies reported on it. On SGA, only 21, so forth. Because of some of these, it's inherent in doing a meta-analysis that every study is going to have different definitions and endpoints and what was included and what wasn't. For that reason, the COE, the middle column, is weak. The confidence level, and by the way, these authors, I hope I mentioned this early, Dr. Jamie Lowe and her colleagues, who are the authors of this meta-analysis, are from the University of Portland, Oregon Health Sciences Center. They are highly reputable, superb, well-trained in research, and great doctors and well-published, just impeccable science. And they would never say something as high confidence if it was low confidence. They know statistics and all that. But this table two is, if you go back and read this article, will be the meat of the conclusions. But we'll show you some of the graphs. Let's look at the next slide.
And I would just add, what gives me confidence, a little bit of confidence, is that the reproducibility of some of the findings. So although there is low confidence in the individual papers, it is for me interesting that there is an element of reproducibility with similar people finding similar things. But I agree with what you said, Dr. Molloy.
Yeah, this study had a cutoff of being published at the end of 2022. So anything published since then isn't included, but a prior meta-analysis might have had a cutoff in 2020, and previous meta-analyses done reached similar conclusions. And there's no meta-analysis or review that I'm aware of that doesn't show an increased incidence of some adverse outcomes in pregnancy in exposed women. So
So
this,
yeah, go ahead.
yes, yeah, birth weight, mortality, and SGA. Here's an example. I'm not showing all of the primary endpoints. This is SGA, small for gestational age. Call your attention to the bottom of this, the random effects model. Prediction interval does not cross 1, meaning that this is more confident than some of the other conclusions and the other endpoints. And the odds ratio, or you're used to thinking of this as relative risk, is 1.76. It means that there's 1.76 times as many SGAs in exposed women compared to unexposed pregnant women. 76% increase. Sounds like a big number. Let's just say it was twofold. If it was double and the event and the endpoint was only rarely occurring, then the absolute magnitude would not impress you as much as the relative magnitude. Let's suppose cannabis exposed women have uneventful pregnancies most of the time and deliver normal babies that are not subject to small for gestational age, preterm, mortality. So if it only occurs 1 in 100 times and you double it, it's now 2 in 100 times. So phrasing it that way, I'm bringing this up because we have to talk to each other as colleagues and talk to our patients, and how we present the data and the risks to patients has a lot to do with how impressed the patients are and what actions they would take, their decisions to use or not use. If you say the relative risk is 1.76, not sure a patient knows what that means. If you say 76% higher, I'm not sure they know what that means. If you say double the risk of something that happens only 1 in 100 times, that may reassure some patients, oh, I'm going to still use. So we have to think about what language we're going to use. Let's look at the next slide, Jahan.
In 1 second, Dr. Molloy, we have another question. Go ahead. Thank
Okay.
you for using the hand raise feature.
Yeah, but because you talk so nicely, I don't want to interrupt you. Um, so my question is, so do they all those study just compare to what? Or how they got the race the
So
ratio?
each
Just
of the
say
50, yeah,
compare
each of
those
the,
one. Yeah, so the
each,
one use marijuana or the cannabinoid and then cannabis, and then compared to those who not used it at all.
right, exactly. Um, Most women pregnant are not using cannabis, so most clinics and big databases, Kaiser or individual hospitals, are trying to look at a database of women that they can use as controls for statistical purposes that are matched as well as they can. for age, for parity, for alcohol use if it's known, for tobacco use if it's known, for other medical issues if it's known, for
Yeah.
socioeconomic status if it's known. They try to control for as many other potentially confounding variables, and that's the comparison group. And that's one of the problems with the meta-analysis is that the control group is either um, characterized in less detail or there's variability in the control.
Yeah, because I feel that if the people who use the marijuana, sometimes they have multiple substance abuse. They will not just say inhale, use marijuana alone. They might get some other drugs. So how do they
Yeah, so
just to
when it's
confound the,
known, yeah,
yeah, which one
tobacco
will be the
abuse,
most impact? Because the combination, right? Not only that
yeah,
you very
exactly.
hard to
Yeah,
isolate just state because marijuana lead and then
right.
because
Well,
they're all together.
And that was one of the
it's,
strengths of the paper. They used adjusted and non-adjusted when looking at studies that had controlled for like
Yeah.
tobacco use and those that had not. And so
Okay.
they were kind of meticulous about, okay, well, let's look at all the data and then let's look at only the studies that have controlled for tobacco use and do we see similar results or are they very different? So they tried to control where they could for that. But again, every study is done a
Uh,
little bit differently to your point. You know, they kind of
yeah. I know
yeah, you're
sometimes it
asking,
kind of difficult. Will be good to
yeah.
have the um push
Well,
the
you're asking a great question because it's an issue for all meta-analysis and pregnancy outcomes. This is the one disease where there can never be a controlled prospective study that randomizes women to
yeah.
cannabis and not cannabis. So there'll never be a study. So meta-analysis and epidemiology is doing the best they can, and attempts
And
are made to control.
and one of the things I think we talked about at the end is they ended up having like among all the studies they looked at, it was something like millions of women were in the total number of studies that they looked at. Like it's a large number of participants. But Dr. Felicia Dawson has been waiting patiently with her hand up, and I wanted to give her a chance to ask a question or comment on the paper we're discussing. Thank you
Good
for
evening. Good evening, everyone. Two things. In these studies, did they discern between legal versus illicit market stuff, and was it all self-report? Because most studies that I see are before most of the country became legal, and so people were just dealing with illicit product and smoking it.
Well,
great
that's an easy
question.
one because this study allowed self-report and tox screens. So women were queried in a lot of these 53 studies, and they were toxicology screens in the others. And when a screen when a screen came back positive, to the best of my knowledge, the women were not queried as to the source or the details of the product.
And do you know if they screen for adverse childhood experiences and mood disorders like depression and anxiety, stress,
I
PTSD?
didn't. Good question, obviously, and no, I haven't seen that. I didn't see that in any of the studies.
But that I'm so glad you brought that up because for the next 2 months we're going to be doing more papers, and one of them, I think it's either for September or October, will be on a paper that looks at those sort of sequelae, and just as you described. Is there mood issues later on? Are there other things that might arise as a result of neonatal exposure? So um, so that we'll be looking at an original paper that focuses on that topic, I think next
And,
month.
and, and even the epigenetics, they're showing that trauma can be passed down through the DNA for multiple generations. That's another thing that I don't see many people considering.
It Good point. It's not the focus of this paper, but it is. There's an emerging database on epigenetic signatures and abnormalities in cannabis users. By the way, the father or the mother that get passed down and inherited. Fascinating.
Yep. Thank you.
All right,
Okay, we'll
great
go to the next.
question. Thank you. Yeah,
Yeah,
next
it
slide.
is. So if you read this paper, there are, by the way, similar graphs, bar graphs, for all of the major endpoints.
And
So
there's
here's
like,
the,
And one more question. She said,
yeah,
how many states have legalized
well,
marijuana?
38
Yeah.
states for medical, and I think it's 24 for what is called recreational or adult use. Is that 38 and
Okay.
24? Is that right?
yeah,
The
I
current
think
score?
that's fully implemented. Some have passed legislation that has not been implemented yet, like Delaware. So, you know, they don't have adult use sales yet, but they have passed legislation. So, the number might actually be higher in 2 years,
Yeah,
for adult use. But yeah, so we're talking, uh, about more than half the country has medical marijuana laws or ways to buy medical cannabis products legally. And basically, half of the US states have some sort of adult use law, either implemented
yeah,
or on the books.
Okay, thank you.
Yeah.
yeah,
And yeah, go ahead.
yeah. Um, so, yeah, shown on this slide, basically the primary findings of this study with a low level of certainty because of the reasons that you guys have already brought up, actually. So the next slide is secondary outcomes, low certainty of evidence of decreased gestational age at birth, NICU admissions, and unlike other previous meta-analysis and reviews, in this study, there were no significant differences amongst exposed and non-exposed for APGAR scores. And other studies have shown that there was a difference. So go ahead. But this one didn't. So strength and weaknesses. Overall, given the limitations of meta-analyses, this was well done, comprehensive, adjusted. They thought of everything. Top-notch, reputable researchers, as I've mentioned. As Jahan mentioned, they adjusted effect sizes and accounted when possible for confounding variables when it was mentioned. Family history of PTSD or schizophrenia was not available, for example. Many outcomes that are relevant were looked at. The fourth bullet, future research. You can tell me what you think about the future research. And as Jahan already mentioned, the strengths of the study was a large number of studies. The initial N was huge, and it was narrowed down
Yep.
to studies that had strong reporting of outcomes of relevance. So go ahead, next one.
And one thing I'd add before going to the next one, just like you said, Dr. Molloy, it's a comprehensive study by its nature. And when they did the bias assessment and the evidence grading, they actually used independent reviewers for that as well. So I thought that kind of adds to their reliability. It wasn't just the researchers who are going to put their names on it and publish it. They had independent reviewers sort of grade and assess things to kind of help with their conclusions and their findings. So for me, that adds to the strengths of the paper
Yeah,
as
okay.
well. And here we
Here's
have
a
some
couple,
quotes that you
yeah,
chose, Dr. Molloy, from the paper, which are really great. So these are the author's own words. Please go ahead.
yeah, you can read them. I don't have to read them, but I'll take a second and pause and you guys can read it. It's something we have talked at Cerium and our little research group has talked about this a lot as rescheduling, the wheels are turning for rescheduling, and at the same time, cannabis is becoming more potent, and general use and perinatal use is definitely increasing. And but wait, but other studies that come up with data that about 50% of users, of daily users of cannabis, have no intention of quitting when they learn they're pregnant. Daily users. And the second quote just summarizes the study. So yeah, and this one is provocative. We threw this quote up there. Um, What do you think healthcare providers should do with this evidence or these conclusions or this story that's evolving in the cannabis literature? First of all, I do buy it. The level of certainty is low. Do you buy that cannabis is risky and likely to be associated with adverse outcomes in pregnancy? And if you buy that and accept that that is unlikely to be reinforced with future studies and turn the pages ahead a few years, then other researchers, my opinion is that the evidence is overwhelming that this is a true story, because no one has ever looked at this and not come up with similar conclusions. Enough for me to say it's the degree of certainty is as good as we're ever going to know.
Dr. Dawson has another question, has her hand up.
Well, you were asking my opinion, and I actually believe that if the person is using cannabis from a clean source in a safe way, in terms of not smoking it, maybe using an electronic vaporizer for dry flower, or using it topically or orally, full spectrum, in not too high a dose, those kind of things. And if everything else is normal in that person's background, I think it's unlikely that they're going to have a bad outcome. I mean, I know anecdotally many people who have actually did not consume it in a way that I would recommend, but everything looks fine. I think it's a marker for other issues, the issues that I brought up earlier in the talk, even including other complications of pregnancy, like hyperemesis gravidarum, can cause a small baby, or a miscarriage, or ADHD, or autism. I mean, there's actually an association between hyperemesis gravidarum and the very outcomes that are being put on cannabis. And yeah, the bulk of the research we have is horribly negative. But again, it's retrospective, self-report, illicit market sources, used in a unhealthy way, et cetera, confounding things, environmental toxins, environmental racism and toxins coming in from factories, whatnot. There are so many things that can cause bad outcomes in pregnancy. And I believe, including stress and epigenetic changes, that cannabis is a marker for other things, but cannabis is getting the focus when it's actually possibly other things. That is what I believe.
Yeah, you had
I like that
multiple
as
layers.
cannabis
Yeah.
as a factor, right? And maybe it's not always a bad factor. It's not always a good factor. It's a factor. At least that's how some other researchers have looked at it. But I think that would be an interesting hypothesis to look at in future meta-analysis over time, is as the supply of cannabis becomes more consistent, regulations get stricter. As you said, it's cleaner, it's free from impurities. Do some of the risks go down? Do some of those risks stabilize? Maybe there's more information about proper dosing and things like, as consumers become more educated, do some of the risks that people are seeing go down as they're able to really look at how people are using these products. I think that might be a benefit of more regulations, is that certain health risks might go down, but we have to balance that out, because I always feel like people hear that one cannabis fact becomes like a whole novel. You have to balance out some of those things. But Dr. Molloy, did you want to?
No, but it still leaves me confused, Dr. Dawson, about how to have conversations with my patients, one-on-one, just me and a patient behind a closed door. We're in the exam room. I don't feel like I have enough data or information to give sound advice. And right now, the best I can say is that we suspect there might be an association.
And I was just reflecting, just briefly, I was just reflecting with someone not too long ago that when I went through medical school in residency, I trained at Morehouse School of Medicine, trained at Emory's residency. cannabis, it wasn't a big deal. I mean, it was like considered a drug, but we were not taught all this stuff that's in the news and the being out here now. As I can tell you as a student and a resident, it was like, yeah, if they tell you that they're doing it, you might want to stop that, but it wasn't like, oh, it can cause this, it can cause that, it just wasn't like that. So it's just interesting to me how you come through the training and not think much of it, but once I don't know, it just wasn't an issue like this
Yeah,
back when I trained.
sign of the times, maybe.
Yeah, maybe so.
And speaking of sign of the times, this is a very active area of research. And thank you, Dr. Dawson, for the great comments and sharing your experience as well. But there's a lot of other research that just came out, some of it with more recent data, different data than this study looked at. Like I said, this study's cutoff was 2022, as we mentioned. It's also part of a living meta-analysis, and in the paper, there is a link to their website where they continuously update this meta-analysis for this cannabis evidence program they have, which is very interesting. And moving on to our next slide. I don't know. Oh, Dr. Molloy, did you have a comment on?
No, just more summary. Yeah.
And we talked about this already, but Dr. Molloy, you're very much in these journal clubs. Okay, we've talked about this paper. You have someone walk into your clinical office who either might be a cannabis user and might be getting pregnant or has questions about it. Is this a study where you print it out and you hand it to the patient to take home to read?
I think the ACOG paper or the Surgeon General report are more relevant for patients than this meta-analysis. But and I don't know how I feel about the low certainty of evidence. It's because of all the reasons we've discussed, really.
So it may be difficult to try and change behavior if you're trying to change behavior in a vulnerable individual with information that says low level of confidence. Like
Right.
it may be difficult to get that desired outcome, but I think at a minimum we can say there's a lot of unknowns here. And if you want to reduce risk, hey, don't drink caffeine, don't use cannabinoids. These are all the things you can do to mitigate risk. And I think it's always an approach to any sort of disease or treatment or like for health in general.
I think it's funny that in my informal surveys of pregnant women among my patients and daughters' friends and everybody, everyone knows alcohol is an issue when you're pregnant. And I haven't been able to find one member of the lay public that is aware that this is even an issue that they should be thinking about.
And I think there's a lot of historical evidence, even going back, I think, to the Egyptians about cannabis and using it to induce labor and using it for things like that since ancient times. So I think there is a little bit of maybe sort of that ancient use has been around. So maybe it's been used for so long, it's one of those things that people don't really question. And maybe when people think about it, they think, oh, maybe the person's just using it once or twice or infrequently for morning sickness. It's not a big deal. And I think we're worried about maybe a regular user of any substance and why hasn't that reached the same level as alcohol? Like people know it without even having to read the label on alcohol, right? Or read that placard. Like it's pretty well ingrained. But maybe future studies will help with that messaging. So once again, we have a free membership for purectrialsplus.com. This can give you access with just your email address to blogs and other notices about our events. And just want to remind you that our journal clubs are the first Tuesday at 8 p.m. Eastern. Same Zoom link, same Zoom channel. And this summer, we're doing a pregnancy and development 3-part journal club. So each month will be a different original paper, fairly recent publication discussing different aspects of it. So tell your friends, tell your colleagues, and it would be great to see you all again. I don't know, Dr. Molloy, if you had any closing thoughts as we reach the end.
No, I think if you can reach out to us with suggestions for further journal clubs, we try to pick topics that are clinically relevant and interesting, driving under the influence of cannabis, cardiovascular, anxiety. Any topic that you think there's been a good paper on, you can pitch it to us, and we're always listening.
Excellent. Well, thank you so much for attending, and thank you, wonderful docs, for your participation, sharing your comments and questions, because that's what it's all about, just talking about a paper and getting through the figures. There's so much evidence out there, so we rely on your feedback, as Dr. Molloy said, to help us pick these topics. So look forward to seeing you next month. Have a great week.
Bye-bye.